So thank you very much. Aren't those nice flowers? That picture's from 2 years ago in front of Eisenhower. It's just beautiful. They do such a nice job outside. I came to talk tonight about heart surgery. And when Bill asked me to talk, I didn't know exactly what I should talk about because some of the stuff that interests me is kind of gory and not really good to show on a screen, although I thought maybe I should. That would be really pretty interesting. But I thought I bought the heart-lung machine over here before. I'm not sure we've ever brought the instruments and all the equipment that we've used before, but I thought I would go through tonight I've got about 12 slides about cardiac surgery and why we are where we are now, and how, in my opinion, cardiac surgery has changed the face of Medicare, face of Social Security, and the way trials are performed in this country, and the collaboration across different subspecialties. And it all dates back to 1989. And I got into heart surgery because I was doing general surgery, and honestly, I saw a lot of surgeons that weren't good surgeons. And it was always just what the incision looked like. If the incision looked good, then everything was going to be okay. And heart surgery and brain surgery at that time in the late 80s was where not only did you have to be technically capable, but you also had to be someone that could take care of patients who were critically ill. You could evaluate patients and help make a differential diagnosis about what their issue may be. And it wasn't just a technical procedure. I was a math major for my first 3 years in college, and a lot of the hemodynamics and the issues that are related to people who are critically ill kind of was right down the alley that I really enjoyed. So in 1989, and most people won't realize this, but in 1989 is when Medicare told the Thoracic Surgery Group, the Society of Thoracic Surgeons, that they were going to cut physician reimbursement for heart and lung surgeons by 15%. And our leaders at that time said, wait a minute, that's not fair. You shouldn't do that. But more importantly, what came out of that was that our society decided we needed to let people know what we really did, because most people don't know what an interventional cardiologist really does. They may not know what a pediatric cardiac surgeon does, and they don't really know, for the most part, what cardiac and thoracic surgeons do besides just operate. So in 1989, the Society of Thoracic Surgeons established an adult cardiac database. It's one of the largest and most comprehensive clinical databases still in use. It's the reason that there is now a database for neurosurgical procedures. It's part of the reasons that there's now called an ACC database for patients who come in and get stents for emergencies for closed coronary arteries. It contains over 9 million procedures from over 1,100 sites and including 3,651 surgeons worldwide. It involves data from the European database, the Australian database, the Asian database. Everyone provides data to this database, which is stored at Duke University. They use audited data. All the data that's sent in is audited, and it provides the foundation for multiple risk models, performance metrics, health policy decisions, research, quality improvement, and also a trove of research studies to improve the care of patients in cardiac surgery. It's a database where I told you it's going to be boring. It's a database that you can go into and not only find out what is happening in Europe for a particular procedure, but you can, and what we use it for a lot of things here. We can go in and we have probably 70 like hospitals that are our size that do about the same number of cases to find out what their data is compared to ours to see if there are things that we aren't doing as well as like programs. Or we can look up at the top 10 programs in the country and see what they're doing different that we may be able to aspire for and change some of the things that we do to make it better. It's an amazing database. We provide data to this database every quarter. It's gleaned. We have people that work here full time, and that's all they do. When this started at Eisenhower, I think in 1993 or 94, it was free. It's still a voluntary database. I think the hospital now pays about $85,000 a year to be a member because of the software that's required. It provides insights into current clinical practices, such as the change in demographics among our patients who undergo aortic valve surgery, minimally invasive techniques, patients who undergo bypass surgery, and some of the more adoption of procedures around the world, such as ablation for atrial fibrillation or closure of your atrial appendage at the time of surgery. It's a foundation for national benchmarking of all programs. You can be ranked for any procedure. You can be ranked for the amount of antibiotics that you give a patient. You can be ranked on what percentage of your patients go home with aspirin. You can be ranked on how well you do in each type of procedure and how well all those patients stratify out for not only mortality ratings, but for risks and complications. It's regularly updated, recalibrated risk models from the data that they get. Feedback's given, quality reports to hospitals, surgeons. We report, as every other program that does heart surgery in California, we have to report every year to something called C Corp, our data on how well we do surgery. And you may or may not know that all this data is public. You can get on their website. You can see what happens here. They have a list every year of the top 5 and the bottom 5. And that one's usually in the newspaper. It is actually, that one is, but it's good for consumers that are savvy to look at if they want to pick where they get their health care, see what their doctors are capable of doing, to say, I'm not going to go here, I'm going to go there, or I'm going to go there because of this reason. They also have that data available for percutaneous coronary interventions. They have it for neurosurgical procedures. It's amazing stuff that is not well known. It's voluntary, as I said. It's essential data that's given to Centers for Medicaid Services. It's data that we provide, I say we as a group, provide to the FDA, to the American Heart Association, to the National Quality Forum to help inform healthcare policy for the country. It's used by Congress and what we call the CPT, the Department of Medicare Services, that actually every year decides how much someone gets paid for a procedure. And it helps make national decisions about what or what should not be a new procedure that's provided to the community as a whole. So I'm going to go through some of the more common surgical procedures. I'm going to talk about COVID and what COVID did to heart surgery more than anything else, and how it changed and really shifted the way that we do things, especially with valve surgery, which would not have happened without the database and would not have happened without COVID causing the problem that it did. Isolated coronary artery bypass graft surgery, CABG. That means that's procedures done by itself. It's not done at the same time as an aneurysm. It's not done at the same time as a valve. It's done just for coronary disease. In 2022, it was 72% of all the cases reported, which is the most common procedure done. Of all the cases captured but not coded by the database, it was 56% of those cases, which I'll explain later. But we were finally similar to 2019 with pre-COVID data. And there were almost 300,000 CABG procedures performed nationwide. And over COVID, there was a 16% drop in that volume. That volume was all elective open heart surgery, not the emergency surgeries that were being done. If you look at valve procedures for the most part are elective procedures. And with the emergence of COVID, the COVID pandemic, the valve procedure volumes dropped. Isolated aortic valve surgery dropped 40% in 2020. It's amazing how far it dropped relative to 2019. That number has never come back up nationwide at all. And what happened because of COVID? Transcatheter valve implants, which we had been doing for about 3 years, 3.5 years here, some places 5, 6 years, took a accelerated market share of all patients who got aortic valve replacement therapies. And it's accelerated over 60%, 66% higher in patients who get surgical valves now. Eisenhower Hospital became a benchmark group for transcatheter valves during that COVID period because we had the forethought, say we as a group, myself, Dr. Khanna, Dr. Pangalori, Dr. Frutkin, some of our nurse practitioners or physician assistants actually sat down and looked at the data and said, what can we do to keep doing valve procedures for our patients here and have it be safe during COVID? And some of the things that we implemented that we heard were being done around the country or could see was that patients weren't going to the intensive care unit after surgery. Patients weren't being admitted to the hospital after surgery. We took that a step further and said, maybe we don't have to put these patients to sleep to do their transcatheter valves. And so over the course of 2022, starting, I guess in March is when that really hit us. And for about 2 months, we really didn't do anything. And about May, we started doing transcatheter valves, the ones through the groin or alternate sites with the patients awake, almost like you would get a colonoscopy. You're awake, but you don't know, as far as you know, you're flying to Tahiti. You're kind of out of it, but not with a tube in your throat. We stopped sending people to the intensive care unit and sent them to the telemetry floor with nurses who came to the procedures to be trained in how to take care of those patients. We became, over the course of the next 1.5 years, a national benchmark program. I don't know if someone's talked to Mended Hearts about that yet, but we became a national benchmark group for outpatient valve procedures over that period of time. And our valve volume in 2020 went up compared to down. And we've maintained that. We are a national benchmark center. We were the first one to provide educational services to other programs coming here to learn how to do that. And during that time period, our hospital as a group became the California leader in the number of alternative access valve procedures done. So if you had vascular disease in your groin or in your chest, so we couldn't put the valve in through a peripheral blood vessel. We started making an incision in your carotid artery, which sounds kind of strange because it brings blood to your brain, but we make an incision in the neck, put the valve through the carotid artery into the heart. We're a national teaching center for that procedure. We've been doing that since about the time COVID hit. We're very proud of our ability and the number of patients we can provide that service to. Coronary artery bypass surgery. It's the most common procedure performed year to year. The red is Eisenhower's data. Last year, we performed 167 isolated coronary bypass surgical procedures. Last year, cardiac surgery at Eisenhower, we performed over 700 cardiac surgical procedures. The average age nationwide, and it's been fairly standard since 2015, is 65 and a half years. At Eisenhower, our average age for bypass surgery is 75 years. The national risk of operative mortality, and operative mortality is considered death either in the operating room or death within 30 days of surgery. That is an operative death, according to the statistics that we have earmarked. That's how we classify operative mortality. The national risk of dying with coronary bypass surgery is 1.76%, and at Eisenhower for last year, it was 0.2%. We're very proud of that, from the pre-op nurses to the surgical nurses and staff to the extreme excellent care the intensive care unit gives, to the telemetry nurses. And that goes even further to some of the skilled nursing homes and the home health care groups who come to our meetings with us to help us all be in line about what we want for our patients. Off pump, or what we call beating heart surgery, hasn't really changed since 2015. A lot of comparative trials comparing procedures done with a heart-lung machine and without a heart-lung machine have not shown any real benefit in either quality, outcomes, risk of repeat myocardial infarctions, or in survival. And since 2015, there's been a small decline in the number of off-pump procedures, down 14 to about 10%. Eisenhower, last year, we did 8%, which is pretty consistent for us. I don't think we have ever been over 10%. We're not a large off-pump beating heart surgical center. There's been no growth in robotic open heart surgery. They do that. Robotic heart surgery does about 1% of all isolated coronary bypass surgeries. And in fact, since 2015, there's not been any new robotic heart surgery centers that have opened, and there's not been any new robotic heart surgeons. Most robotic heart surgeons do about 15 to 20 robotic heart procedures per year, except for two other gentlemen. It does have a place, a niche place in open heart surgery, but it's not something that has shown benefit really in any way except cosmetic results. That's the way most people feel about that type of procedure. I put pump head in. We hear a lot about pump head, which we can talk about later if you want. The cognitive and the mental changes that a lot of patients get with open heart surgery. The New England Journal of Medicine has done 2 or 3 different studies over the years to find out if that is a real cause of using the heart-lung machine, and for the most part, it has no merit. It has no evidence that there's anything called a pump head. There is a phenomena in people who are highly stressed, especially in motivated individuals, that they do get this neurocognitive decline after any major procedure, including gallbladders and or hernia repairs, but not specifically related to open heart surgery. Aortic valve replacement surgery since 2015. Isolated aortic valve surgeries declined since 2020. It's not changed like we discussed. Transcatheter approaches for aortic valve replacement therapy have accelerated nationwide. Some of that is because of COVID. Some of that is because with COVID, there were several trials that were started nationwide to determine if we could take not only the older, higher risk patients for that, but now younger patients down to 65, 68, low risk patients who typically would get a surgical valve replacement to see whether or not they would benefit from a transcatheter valve. And the results of those studies showed that for the most part, yes, that is true. Mick Jagger was 71 when he had his transcatheter valve done. It's a very safe procedure, and last year we did 209 of those procedures here at Eisenhower. Surgical valves still occur. Most surgical valves now in patients are done with what we call root enlargements, or opening the top of the heart where the aortic valve sits so that we can put the largest valve in place that could possibly be put in, so that down the road, if that valve fails, you won't need open heart surgery again. You'll be able to have a transcatheter valve put inside that valve, what we call valve in valve. We know surgical aortic valves, about 15% of those fail at about 15 to 20 years. 85% of them still work well, but for the people that those valves fail to work, we used to reoperate on all those people. For the most part now, they get a transcatheter valve. They don't need open heart surgery again, which is wonderful for the patients. We use a collaborative approach here for all our aortic valve issues. Every Wednesday morning, there's a group of about 14 people. We meet. We talk about every patient that has aortic valve disease that is on the table for a procedure or on the table to be monitored for maybe future valve replacement. Transcatheter valves have the same mortality as open surgical procedures. That's not the reason that we changed. The quality of the procedure is the same. However, the recovery and the return to activity, the lack of an incision, the lack of need for pain medicine, it's dramatically changed. You know, your recovery is a couple of days. Mitral valve surgery in the country, the average age is 62. A lot younger in a lot of places because of intravenous drug abuse. A lot of young people get mitral valve replacement because they do intravenous drugs. The risk of mortality for the mitral valve replacement is 4.38 nationwide. You need your mitral valve replaced. Surgeon tells you the chances you'll do well are 96 times out of 100. That's pretty much true. The death rate's 4%. Last year at Eisenhower, our mitral valve death rate was 0.97%. I'm saying again, that has to do with the factors of the way that Eisenhower has assisted all of the people involved in the cardiac service line here and taking care of patients. There are 37 robotic mitral valve surgery centers worldwide. The number of cases has not changed in the last year. It's about 11%, 12% of cases, 3 to 6 procedures per surgeon. I think the highest volume robotic mitral center in Southern California is still Cedars. They try to do one every Thursday. MitraClip volume has increased, and for those that don't know, there's a different way to treat mitral valve regurgitation now. It's with a clip, almost like a old clothesline clip. It's what it looks like. It's put through the groin. You puncture one of the chambers of the heart internally and get to the mitral valve, and you clip the 2 leaflets of the valve so it doesn't leak as much. We have a very active program here under Dr. Pangalori and Dr. Frutkin's direction. It's not affected the surgical volume at all. We are looking, hopefully, within the next 5 years of transcatheter mitral valve replacement as technology improves. So if you need a mitral valve performed, maybe you won't need to have surgery with an incision done on your chest. We rarely put in mechanical valves, which are pyrolytic carbon. We rarely use mechanical valves anymore. They last forever, but the tissue valves, although they degenerate, we can now put transcatheter valves inside of those valves so patients don't need to have surgery and hopefully can decrease the risk of them needing anticoagulation. One of the things I think we're most proud of from a surgical standpoint here is that of left atrial appendage occlusion. It's been documented in a lot of publications that surgical ablation or maze procedures and left atrial appendage occlusion for patients with atrial fibrillation continue to be an area of significant opportunity for improvement in the care of patients along all spectrums. So if you have atrial fibrillation, the reason most people are on Coumadin is there's a little appendage on the back of your heart called the left atrial appendage, which is the place you form blood clots. And those blood clots can break free from that appendage, get in your bloodstream, go to your brain, and cause a stroke. It's one of the reasons that the Watchman device has become so popular, is that that can occlude your appendage. You can get off your blood thinner. In 2017, the Society of Thoracic Surgeons, based on our database, published a clinical practice guideline for atrial fibrillation to determine and to tell physicians that we believe that if you occlude the atrial appendage at the time of surgery, there'll be a decrease in the stroke rate along these patients. There'll be a decrease in anticoagulation in those patients, and there'll be a decrease in the risk of complications related to anticoagulation, bleeding problems in those patients. Despite that publication, nationwide last year, only 47% of patients got their left atrial appendage occluded with surgery. At Eisenhower last year, 98% of patients who had open heart surgery had their appendage occluded with surgery. This study in 2017 said that concomitant maze procedure ablation in patients with atrial fibrillation should have their appendage occluded. 2.1% of programs nationwide, it's just amazing to me, perform maze procedures on people with atrial fibrillation who are having coronary bypass procedures. Last year at Eisenhower, 100% of those patients. There's been no change in utilization in any year after the clinical guidelines were published, which is hard for me to fathom. And the last area I just want to touch on to tell you why this database is so important to programs who are looking to grow, looking to be on the edge of what's happening, is that in 2022, there were 29 original articles published based off physicians or researchers who studied the database to ask specific questions. 8 regarding bypass surgery, 10 regarding valve surgery, 7 regarding arrhythmia surgery, yada, yada. One of the studies had to do with women undergoing bypass surgery. Women are 24.5% of the total number of bypass surgeries done. The rest of them are men. Women have a higher operative and overall mortality compared to men. We don't exactly know why. And a couple of the papers that were published last year had specific concerns regarding what those factors may mean and have reached out in publications to all the people who provide data to the STS database saying, let's try these different types of modalities, which are safe, and see if that number changes and what we can do. Another one regarding aortic valve surgery had to do with bicuspid and not tricuspid valves. People who congenitally have an abnormal valve, whether they should have a SAVR, a surgical valve, or a TAVR, a transcatheter valve, which one they should have and why. And that study pretty much showed us that patients with congenitally abnormal valves should have open surgery because the transcatheter valves don't seat well because of that congenital abnormality. Mitral valve regurgitation, clip versus surgical repair, aortic aneurysm, valve type and survival. Arrhythmia surgery, one of the big studies last year, had to do with patients who develop atrial fibrillation after open heart surgery, and compared patients who were given anticoagulants and patients who were not given anticoagulants to see if there was a difference in stroke rate, death rate, or survival, and there wasn't any. And the paper posed the question, let's see what happens, but we think maybe blood thinners shouldn't be given to patients over 75 years of age who develop postoperative atrial fibrillation. And then the last paper I just mentioned is red blood cell transfusion. The risk of red blood cell transfusion in the 7 days around surgical time is 40% nationwide. Last year, Eisenhower's risk of red blood cell transfusion was 19.3. The risk of thromboembolism, mortality, readmission, and length of hospital stay are affected by whether you get a blood transfusion or not. Unfortunately, not all of our aging population has the same improvement in outcomes. Retrospective analysis since 2011 has revealed over 1 million patients are female or Black and had higher rates of hypertension, stroke, kidney disease, chronic heart failure compared with white patients, and more importantly, higher overall mortality. Since 2022, and some of this has been done because of the woke environment we live in now, people actually went into our database to look back and say, let's do something. Let's look at this data and look at all these other issues that are involved. There are now at least 12 working groups in the Society of Thoracic Surgeons that are devoted to implementing standards to narrow the gap of this problem, and the data on that is pending. So, the Society of Thoracic Surgeons database helps establish evidence-based best practices, the best practices. It documents quality improvement. And that's what we want. We want improvement in our quality, something we can document on paper and say, this is why we do a good job. The ultimate goal is improvement. It's not measurement. Eisenhower continues to be a top 50 program nationwide. That's all comers. That's academic centers. That's community hospitals. That's teaching hospitals. It's the top 1%. We are highest rating at Eisenhower in the nation is for coronary bypass surgery, aortic valve surgery, heart failure treatment and surgery, arrhythmia treatment and surgery. And I think we're all very, very proud of that. So I will finish with this and say that Eisenhower is the tip of the spear. And we are that because our administration gives us time, money, equipment, personnel to do what we want to do. We look over the horizon. We have a lot of people who say, here's where we are, but we're looking to see where we can go to be better. We ask everyone who's involved with this to take responsibility for your position and what you do. Look at what you do and tell us what you think that position could do better. Look around the country. Look around, talk to your colleagues. What can we do better? We enroll others to show them what we're doing, to say, get on board. Why don't you come help us? Why don't you be with us Collaboration. And I've always said collaboration doesn't mean we all agree. I can't tell you the number of conferences that, especially valve conferences that we've been at, that there are heated arguments about what's the best for a particular patient and a particular problem. But that's collaborative because we come out of the meeting understanding where everyone stands and what's the best for the patient. And then it's creating clarity and vision, which I think to be a leader, you have to be able to tell your team where you're going and why you're going and to communicate that well. And I think we have a lot of people here in the cardiac program at Eisenhower that are able to do that. And this is a quote I've always liked. If you want to go fast, go alone. If you want to go far, go together. And I think Eisenhower does that very, very well. So that's all I have. I'll be happy to entertain questions about any of this or anything else. Thank you for letting me come. I appreciate it.
Except for the people here in the audience for the in-person, we're going to run around here with the microphone. So please use the microphone, raise your hand. And I'm sure there are tons of questions for Dr. Wilson. And Brett Klein over here, our partner in crime with this whole thing over there, he'll tell us when we have a question out of the chat room, and maybe we'll alternate depending on the amount of questions that we have. So first question, where's the mic at? Yeah, Carol.
I have it. Thank you. Thank you, Dr. Wilson. Thank you for all you do. It's a pleasure to represent you to the patient when we're out there in the field. My question is, a lot of patients are talking about their sternum closure being a plate. In fact, more than one, instead of the wire. Could you explain the trend that we're seeing in sternum closures after coronary artery bypass surgery?
So the question is, a lot of patients who have open heart surgery now, for some reason, are being closed not with the old stainless steel wire, but with a plating system. And why is that? One of the things that has happened at Eisenhower forever is we're involved with a lot of clinical studies. And 2011, 12, I guess starting in 2009, we helped devise a sternal closure device that wasn't wire. Ultimately, that device was sold to Stryker and became part of their armamentarium for sternal closure. That device is used for other long bones now. It's not used for sternal closure anymore. We've been involved with sternal closure devices. We're involved with narcotic usage or lack thereof in studies. We've been involved with laser heart surgery. But what has happened for us for sternal closure is that we have decided, with data from the databases, that, and let me digress a little bit, bone heals when it's compressed, and it heals much faster when it's compressed and doesn't move rigidly. That's from the orthopedic data. And one of the things we learned with the sternal closure device that we had implemented or helped design here was that looking at bone scans and CAT scans, that the devices, the plating system and the devices that are used to close the sternum that way rigidly pull the sternum together harder, and that compression causes you to make more bone tissue faster. And it can be seen on a CAT scan. It can be seen on a bone scan that the bone heals faster. And not only does it allow the bone to heal faster, it allows it, the plating system allows your sternum to be stronger in that interim. So patients can do more than they used to do. And that's what we've been trying to slowly, I wouldn't say slowly, but try to teach everyone else that that's the fact. I'd say probably 70–80% of patients who have surgery here have sternal closure with a plating system. And the most common plating system we use is a titanium plating system. You'll get 2 plates, sometimes 3. They're as thin as a business card. They're about as long as your middle finger or wide as your middle finger or index finger. That's how long they are. They're very small. And each one of those plates, we put 8 screws in. That plating system allows the patients to use their upper arms quicker. It allows them to reach over their head. It allows them to roll over easier. Some of Dr. Logston's patients, he started a study on how's the best way to say this? Reinstitution. He's a big weightlifter, in case anyone here knows him. Reinstitution of upper body strength exercises with dumbbells within 3 to 4 weeks of surgery. And the patients who are enrolled in that get CAT scans, bone scans, to see if there's a difference in what's happening. But the goal in that is for patients to become more active quicker, instead of what we used to say, you know, don't lift anything heavier than a chair. Don't push up when you stand up. Patients are able to do that now. And that's the main reason that we have moved forward with that. I will say the other reason that we moved forward with that, honestly, is that in 2014, Medicare saw that that was an advantage, and they used to pay us extra $200 if we close someone with a plate. And the data from the database showed that the readmission rate for sternal problems, for sternal drainage, the readmission rate for sternal wound infections in high-risk patients went down. And so by closing someone with a plate, even though it's probably $10,000 or $12,000 more expensive for the instrumentation, it saved the Centers for Medicare Services money on the back end because they were fixed and they paid it up front. We don't get paid that anymore. They quit doing that in 2017. But we still use a lot of that. And the plating systems have improved dramatically at this point. We use an electric, we use a Benford 5000 screwdriver.
Thank you.
You're welcome.
Anyone else? Who goes first?
Thank you. Thanks. You talked about the LAA, the left atrial appendage, and the closure that you're doing. Is it, in the statistic, you said 98% or something like that when you do surgery is done? Is it done for patients that don't have AFib as well? They put that device in there while you're doing surgery?
So the 2017 study said that if you have atrial fibrillation and you have open heart surgery, you should have your appendage occluded. The data shows that you will benefit. I took it a step further here at Eisenhower, and I said, well, we know patients, we don't know which patients post-operatively from heart surgery are going to get atrial fibrillation. We don't know. We know about 25% of patients who have open heart surgery are going to get atrial fibrillation after surgery. And so why wouldn't we clip everybody's appendage? Because we don't know who those people are. Those clips cost the hospital $800. They don't get reimbursed for them. But we can't guess really which patients are going to get AFib after surgery and which ones aren't. But I decided that if we're going to clip the appendage, we're just going to do it on everybody because there's not really a downside to it. There's not a risk involved. This clip, I mean, I grew up in Arkansas. My parents ran cattle. I took care of cattle my whole life. So this clip looks like, it's a device that looks like what we used to use on bulls. It's just a big round circle on a hand device. And you take the appendage, you put that over the top and you let go and it just occludes it. It's closed, it adds probably, if it adds 15 seconds to the procedure, I'd be shocked. It's a very straightforward, easy procedure. It doesn't have a risk factor related to it. It doesn't, in my opinion, have a downside related to it. You may say 70% of people aren't going to benefit from that because they're not going to get atrial fibrillation after surgery. But 25 to 30% of people are. And if I can stop them from needing a blood thinner by putting that clip on ahead of time, then praise the Lord, I'm happy I did that. On the other hand, the way I put it in my head is that some of those people that have heart surgery may get atrial fibrillation as they get older from some other reason. And if they did, we took care of the problem for them here. The doctor's going to say, oh, you have atrial fibrillation. Dr. Wilson or Dr. Larson clipped your appendage when you had surgery. We don't need to put you on a blood thinner. You know, I'm happy for that. We have no data, however, that benefits those patients. That we do give patients informed consent beforehand and tell them that we are doing this if they want us to do that. To decrease the risk of stroke if they get atrial fibrillation. So it's not something we do without not letting patients know. But that's why we do it on everyone. That's why ours is 98%. And I won't be surprised if in the next couple of years, there's not a study out that says that's appropriate. The Cleveland Clinic also does that. Texas Heart does that. I know those places also do that. And how do I know that? I looked at the database, you know.
Yes, Dr. Wilson. Dr. Wilson, in regards to ongoing improvements of medications, has that altered the amount of CABG that you take place, or certainly how you could go ahead and do differently a procedure with CABG with the new medications out now?
The question is about new medications that are available to patients now, and if that has decreased the risk of someone needing open heart surgery for bypass, and the answer is no. Not the first time around. It's been a lot has changed in the world of cardiac procedures with regards to stents, drug-eluting stents, procedures to open arteries in patients who have diseased arteries in 1 or 2 coronary arteries instead of 3 that may keep them from having surgery now and or ever, or delaying it till they're older. We have seen, however, since around 2008, that the majority use of almost everyone now of lipid-lowering agents, medications have decreased the risk of people needing repeat heart surgery. So the risk of repeat heart surgery at 12 years is 10%. And the risk of repeat heart surgery at 17 years is 12%. It's very, very low. And I think lipid-lowering agents, better control diabetes, better agents to treat high blood pressure and heart failure have played a major role in improving patient outcomes from coronary disease.
Talking to it, it's okay.
Thank you, Dr. Wilson, for being here tonight. I have a 2-part question. One is you're talking about the in-valve.
Valve in valve.
Right, procedure. Say a person with a leaky valve, you've heard that before. Could that be a procedure that would help solve that problem?
So the question is a leaky valve that's artificial valve or your own?
No, that's the original valve. And it's in my case, I was an athlete early in my life, and I had an enlarged heart. The heart reformed, but the valve didn't quite. It was still bigger at the top. It didn't conform, didn't come back. So I developed AFib.
Mhm.
That's the other part of my question. Do you think that leaky valve could have helped been a contributor to the AFib,
I'm assuming you're talking about your mitral valve
right? The top
or your
of the aorta,
so your aortic valve.
on the left.
So the question is in regards to who is a candidate for a transcatheter valve. And right now, the FDA criteria for a transcatheter valve is only in patients who have aortic valve stenosis or narrowing of the valve. That's the only indication that that is approved for. We do an occasional off-label transcatheter valve in patients who have leaky valves, but it's not approved yet because the reason we don't do that is that the valves have to grab a hold of some of your tissue and are able to stay where it's going to stay. The stenotic valves have calcium and scar tissue on them, and the metal frame on the outside is able to grasp hold of that tissue and actually stay rigid and in place and not leak. And for patients who have leaky valves, the tissue seems to be redundant and stretchy. And so it's hard to make a valve that will not become loose or stay in the same place. There are studies going on now. There are trials going on with different types of valves. I wouldn't be surprised within 3 or 4 years if that's not on the market, but it's not right now. In regards to atrial fibrillation, we do know very clearly that the onset of heart failure or an enlarged heart due to heart failure or an enlarged heart due to a leaky valve can lead to atrial fibrillation. And I say that's kind of like a light cord to a lamp. If you stretch that cord, your light's going to start flickering because the electrical insulation doesn't work as well. And, you know, atrial fibrillation is abnormality in your electrical current in your heart. And it's a result, in my mind, can be a result of stretching of that electrical current, which happens when your heart enlarges, you get atrial fibrillation. And I think it's a large reason why, for the most part, that it's hard to get back in a regular heart rhythm. Sometimes you can be shocked if you put on medications, but for a lot of patients, you live with atrial fibrillation the rest of your life.
And it's my understanding that can be corrected, but it's a lot of times it reverts.
It can.
It goes
And
back.
so most patients who have atrial fibrillation, who have heart surgery, we do a maze procedure, which is an ablation procedure to try to keep you out of atrial fibrillation.
Okay, thank you.
This is a little bit self-serving, but I know you're a fan of amended hearts and what we do in the hospitals. We've been doing this since 2001 when this chapter was there. We have a group of people, now 12 of us between the 2 hospitals, that go around and see your patients and any heart patient or their family. I just wonder if you would comment to the people that do all this kind of hard work and the love to do the volunteering as to what it means to your patients.
Oh, I think mended heart means, it probably means more to the families than the patients themselves until the patients get ready to leave the hospital the last day or two when they actually can start remembering what's happening again. I have a smile on my face every time I see one of the mended heart volunteers, and the I wouldn't say effort, but the time and the diligence and the caring for other humans that they put into what they do. And the number of families that I see in the waiting room afterwards that have already spoken to someone and have paperwork, and the patients upstairs that have been told certain things. And I go, yeah, that's right. That's the way it is. The number of patients or families that come back to my office that remember the name of the Mended Heart volunteer that saw them. It's very touching. It means a lot. It means a lot that we can allay the mental angst and make people feel better about what's happened to them, make them understand that there's other people that have had this, that have gone through it, and there's another side of it, and that it all happens hopefully to make their lives better than what it's been before. I think it's a godsend. You know, we had talked over COVID, the patients who, you know, all the patients that had COVID that were in the hospital, or the ones that had to come in for emergency surgery, not just for heart surgery. It was isolated, no families, no one could see you, and how much effort we put in to do telemeetings with the patients with mended hearts over COVID. And it's a wonderful organization, and I think Eisenhower's blessed for the direction that we've had with you, Dick, everyone else that's been very involved with us. I couldn't be more happy.
Thank you very much. Are there any other questions? We're kind of at the end of our hour here, but
Okay.
while Dr. Wilson is still here, and just that as a personal note, I had open heart surgery, not here, but down in Anaheim in 2002, October of 2002. And I went to cardiac rehab here at this hospital when it was a little small place compared to what it is now. And Dr. Wilson came and talked to us in February of 2003. I'm almost positive that was my first meeting I ever came to in Mended Hearts. It was, I was in cardiac rehab at that time, and I believe that he was absolutely instrumental in my thought of volunteering and trying to be part of Mended Hearts. And I'm indebted to him for that. So thank you very much.
Fantastic. Hey, Bill, I do have one comment from online, which I want to read to the doctor. It says, "Hi, Dr. Wilson. Thank you for saving my life 2.5 years ago. I am so appreciative of you sharing this information, and I'm so glad to participate for the first time. Congratulations to you and the entire cardiology team members on the outstanding low risk of mortalities." One second. Those numbers are truly amazing. And I'm so lucky to have been here and treated by you and the entire care team at Eisenhower Medical Center during the emergency situation. He did have one quick question. It says, "I am curious if there is any data available on latent complications post CAB 2+ years with respect to the closure options, wire closures versus plate closures."
Well, thank you very much for those comments. And we do have a very good care team here. I'm one of the leaders of that, but I will tell you, it's everyone that works in this program together. Wouldn't happen without that. As far as latent long-term complications related to sternal closure devices versus wires, sure. I mean, I've been doing this long enough. I've seen everything. I've seen wires erode into the skin in people who get older, and the soft tissue disappears. I've seen plate screws become loose. I've seen late infections that have occurred in the plate or in the wires because of some other problem, but things do happen. Just like with any other type of surgery, there can be latent problems or complications. And if someone notices something unusual about an incision or a problem with it, they should speak to their local physician or give my office a call. Yeah.
Great, thank you so much.
Well, please, let's thank Dr. Wilson for, please for it.
Thank you.
Thank you.